We're going to see infectious esophagitis. Infectious esophagitis could be mostly due to Candida albicans, or cytomegalovirus, or herpes simplex virus. Infectious esophagitis would be seen mostly in immunocompromised patients, so HIV infection, usually with CD4 count less than 100. Specifically for cytomegalovirus would be less than 50 cells per cubic millimeter. 50 CD4 positive T cells, less than 50 per cubic millimeter. Alright, so the patient presents with esophagitis. The esophagitis is painful when the patient is swallowing, as opposed to esophageal spasm that can occur anyway, in any place, at any moment. If we see oral thrush, then the patient has candida on the mouth and also on the esophagus. That's what we would think. So the first step is usually as empiric treatment. If we begin with a patient HIV positive with CD4 count less than 100 and esophagitis, then we think that it's Candida albicans. This we would see it on endoscopy as pseudomembranes that are erythematous, white, yellow, that are adhered to the mucosa. In the cytomegalovirus, what we would see on endoscopy would be large ulcerations, large superficial ulcerations, and herpes simplex virus would reveal small vesicles that rupture and so ulcerate. This is the endoscopic findings of each one. In microscopy, Candida albicans we will see it as pseudo-hypha and a dividing yeast. Cytomegalovirus we will see it as intranuclear and intracytoplasmic inclusions on the epithelial cells. And herpes simplex virus we will see it as multiple nucleated or multinucleated giant cells, for example the Tzang smear. Now, the management of a patient with esophagitis, we suspect infectious esophagitis, if it is a patient with HIV with CD4 count less than 100, with oral thrush, or with just mild symptoms, we will do empiric treatment. So we will not do endoscopy now. First is the empiric treatment with oral fluconazole. Here we're not going to do the swallowings of nystatin. No, here is oral fluconazole. For esophagitis with Candida is oral fluconazole. So oral fluconazole. If we see improvement, then we continue with the treatment. If there is no improvement, then we go to endoscopy and biopsy. In the biopsy, in the endoscopy, we want to rule out the cytomegalovirus and herpes simplex virus. So we will be looking either for large superficial ulcerations or for these small vesicles or small ulcers. If we see the ulcer, we will biopsy the ulcer and we will see either intranuclear and intracytoplasmic inclusions for cytomegalovirus or multinucleated giant cells for herpes simplex virus. So the algorithm of infectious esophagitis is, if there are no severe symptoms, because if there are severe symptoms, we go directly to the endoscopy. But if there are no very severe symptoms, it's a HIV positive patient with less than 100 CD4 T cell count, then oral fluconazole. If there is improvement, then continue the treatment. If there is no improvement, we do endoscopy. If we find large ulcerations, we suspect cytomegalovirus. Small ulcerations, herpes simplex virus. Pseudomembranes, Candida resistant to fluconazole, in which case we need to give amphotericin B. And if we see a ulcer, we need to do biopsy of the ulcer, and if we see multinucleated giant cells, it is herpes simplex virus. If we see intranuclear and intracytoplasmic inclusions, it's cytomegalovirus.